Dr. Mahesh G, the optimist, and Dr. Srinivas Joshi, the pessimist.
May I request Dr. Ashok Nataraj to take the umpire's chair? Sir, there's a helmet kept there for you just in case you want to save yourself from the blows.
And please feel free to use it.
Thank you, Unni, for giving me, Unni and Manoj, for giving me an opportunity. This was a 54-year-old doctor who came from Palakkad, defective vision for the last 3-4 days, hypertension, no steroids, vision was 6/24, and this was the picture. This was the picture. You can see a serous macular detachment with subretinal precipitates and fibrin-like area in the center. And the multi-color image, nothing much in that. Left eye was normal. And this is the OCT picture. Definitely there is serous detachment with subretinal precipitates, and at the area of fibrin, you can see hyperreflective area. And some precipitates are there in the fluid, subretinal fluid. Choroid is thick. There are some pachyvessels also seen in the different sections. So this is autofluorescence, showing hyperautofluorescence corresponding to the serous macular detachment and hypo corresponding to the fibrin. And and this was a Octa. Octa showed some network, but there was no flow in that area in the sections. I'm not very sure. So I told him, this is, I'll come to FFA and ICG. Fluorescein angiogram shows early hyper increasing in late phase with fuzzy margins. And even in ICG, this picture on the right is ICG, but it is a little late phase. I will show the ICG alone. This FFA is showing definite leakage. And ICG, early itself, there is slight hyper, but it is not increasing much in the late phase. Left eye was normal. So I diagnosed it as fibrin CSCR, no network, no polyp as such. So what I could do, I can't give focal laser. I'm not comfortable doing photodynamic therapy in this fibrin. So I gave something like a placebo, I gave micropulse. So micropulse I gave and then started on eplerenone also. Review after 1 month, absolutely nothing happened. Same vision, it is not progressed, not deteriorated. Same OCT, same findings, nothing happened. But that time Octa showed little increase in the network as shown by George. It was showing some increase in the network, but even in those pictures, the sections did not show any increase in flow. That was one problem. Probably fibrin is masking the whole thing. So I gave Axenrix, and this is 1 month later, the serous detachment has completely gone, and fibrin has not disappeared. All of us know that it will take months for resolution of the fibrin. And macula is dry now, totally dry, but that elongated PED is there, fibroscular PED. So it is definitely pachychoroid spectrum, but suspicious network. Then repeat OCT, I did not show any network in that area. So I just stopped. This is 28/6/2019. So just not even 1 month. So I thought, I don't know what else I could have done. There are different articles. The uselessness of anti-VEGF in fibrin CSCR, Srinivas Joshi will show. But there are 4 or 5 articles which showed, some showed improvement with anti-VEGF, some showed no improvement. There was a meta-analysis of 4 studies which did not show any improvement. So I don't know. But this is, the optimist thinks this is the best of all possible worlds, and pessimist fears it is true. So, Ashok, thank you.
Yeah, once again, good morning, everyone. That was a nice talk by Dr. Mahesh. I once again thank Dr. Unni and Dr. Manoj. So I'll be speaking against anti-VEGF in chronic CSCR. So I'll not go into the details of the CSCR, but the old pathology, what it said was it's basically because of the choroidal vascular hyperpermeability. It might be either due to disorder of the outer BRB or the dysfunction of the RPE or the damage of RPE. So what does the newer theory says? It says the thickness of the choroid in the eyes with CSC and was shown to be greater than in normal eyes, basically because of the increased hydrostatic pressure causing the pigment epithelial detachment, and through the subsequent RPE defect happens the focal leakage into the subretinal space. So what does the VEGF do? it can cause fenestrations, it can cause caveolae, and because of which the microvascular pressure increases and this blood tries to seep in, or the fluid tries to seep in as the interstitial pressure decreases, and that's how we get the local edema or the tissue edema. Well, accepted. Therefore, blocking VEGF may theoretically reverse the vascular changes in CSC. Fine. So this was the pilot study which showed that yes, anti-VEGF injection does wonders in case of CSCs. So let's look at another part of the studies where they did not show much of difference between the anti-VEGF injections and the observation. The most important which we need to know is these studies, they have no demonstration of increased VEGF levels in CSC. We give anti-VEGF because the VEGF levels are high. In fact, when they looked into this in the acute cases of CSC, the VEGF levels were much lower as compared to the controls. So why are we treating with anti-VEGF when the VEGF levels are not increased? The results they quoted is the injection was not better as compared to the observation. We all know what are the complications of intravitreal anti-VEGFs. I need not stress more about it. So this is another study which has very nicely put up where they said that yes, anti-VEGF works, but how long it works? 48 days is the maximum pharmacokinetic effect that any anti-VEGF drug has. So what next? None of the studies have defined the intervals at which anti-VEGF need to be repeated, no long-term follow-up, and mostly these patients are young. And further studies definitely need to reevaluate the efficacy. So look into our experience. We had both no response as well as on the right-hand side, if you see, there was fantastic response with IVL. If you see the pre-IVL and the post-IVL, yes. But the most important is the cost factor. So what are we doing? Are we treating the sign or whether we are treating the cause? How many intravitreal injections? $1 million question. Answer probably might be in millions, who knows? Actually, whether it's a result of the treatment or due to the natural course of the disease has yet to be evaluated. The definitive therapy lies is low fluence photodynamic therapy versus ranibizumab, which is landmark paper, which has shown that yes, PDT does wonders in case of chronic CSCRs. My opponent quoted this as a placebo, but let me quote this as a placebo treatment has really worked in our set of cases. With a micropulse laser, we are actually hitting the cause and not just the sign. So this was the paper published which showed that the micropulse laser has a better than compared to the observation. So these are the rest of the other papers. I'll not go into the more detail. It's a cheaper alternative. The efficacy, I just wanted to show our study in the 577 nanometer. The methods were all analyzed with the spectralis OCT. These are the parameters, and the 5x5 grid pattern was used. When we looked into the 19 eyes of 17 patients, in fact, they responded really well. The subretinal fluid in day 0 was 340 microns, and it came down to 38 microns. And the mean CMT from 428 came to 90. So let's look at some of these examples. There was no evidence of retinal or RPE damage on SD-OCT or fundus autofluorescence. 3 patients did have persistent fluid, which the laser was repeated later. So the case 1, here you can see 32-year-old male who had 618 vision, persistent fluid for 4 months. There was a foveal leak in this patient. Day 0, you can see day 30, it was almost resolved, and day 90, the patient regained 6/6 vision with good anatomical and functional vision. Case 2, you can see a large amount of subretinal fluid here, multiple focal leak points in fluorescein angiography. The patient was treated with laser, and now you can see there is a good definitive resolution of this edema. Case 3, you can again see the subretinal fluid, multiple focal leak points here, and when this patient was treated again, not only was the resolution of the subretinal fluid, but also the resolution of the PED we can see in these cases. So whether it's a PED, whether it's a laser or a PDT, I think that actually hits the cause. And conclusion, it is more cost effective, non-invasive, because anti-VEGF we need to keep on injecting. And of course, what are we, the lot discussion has already been happened. Anti-VEGF is indicated only when there is an underlying CNVM. Otherwise, just a simple CSCR or chronic CSCR, I don't think that really requires anti-VEGF injections. I would like to acknowledge my fellows who have helped me, Nishita, Lakshmi, and Giriraj, in getting me these case examples. And at the end, Your Honor, I would like to rest my case stating that Our patient needs definitive treatment and not hypothetical therapy. The rest, I leave it to your fine sense of judgment. Thank you very much.
How many of your cases had fibrin CSCR in your micropulse series?
Pardon?
Fibrin CSCR, how many? You showed a lot of cases, but none of them had fibrin?
7 cases.
7 cases had fibrin.
I think the
Okay,
court
you
is
didn't show any.
adjourned. Court is adjourned right now, I think.
Okay, thanks.
Actually, it was a great presentation, and I feel Dr. Srinivas and Dr. Mahesh, they represent the two ends of the choroidal neovasculopathy or pachychoroid spectrum. Both of them are right. Actually, my take is like, if you have a fibrin, both of them are right. If you have a fibrin CSR, you wait. If it doesn't resolve, I mean, a fibrin CSR, you cannot wait for a long time, as it was mentioned, because you can create fibrosis, neovascularization, vision loss. If you wait for a reasonable amount of time, things are not working out. I think you should go for an angiogram, ICG, and even an octa. So the importance is you have to get the fluid off as early as possible. If there is an underlying CNVM, it is always better to inject. If there is no underlying CNVM, you find a leak, Dr. Srinivas Joshi is right, you just give a laser, the fibrin disappears. So I think the take-home message is now CSR is no longer confined to OCT or FFA or ICG. You need an octa also, to take care of things. And I feel that is the take-home message. You inject if there is a CNVM, and I think all cases of fibrin CSR, if it doesn't have a treatable focal lesion, better to go in for an octa and rule out an underlying CNVM and treat it so that vision can be preserved. Thank you.
He is still sitting in the fence.
Yes. Has got political aspirations in Kerala, so that.
I know, Srinivas, how could you have managed differently than what I did?
That is a separate CME.
No, you can't do anything else. I am helpless.
The place
One second.
variation works.
We'll come to that. I think basically this is not optimist versus pessimist. This is optimist for anti-VEGF versus optimist for lasers.
Yes.
And not normal lasers, but
Micro-
Either
micropulse
PDT
laser.
or MPLT, whichever.
Yeah, please.
Can I just mention a recent study from my colleagues at Oxford and my colleagues in Holland of PDT versus micropulse. Obviously, not all micropulse is the same, but it showed that PDT half fluence was far superior to micropulse in outcomes. And when I mention this, most micropulse advocates say, well, they didn't have the settings right. So we don't use micropulse now for PDT.
Yeah, because we
use
use it
PDT
because
instead.
it's a cheaper alternative for the patients.
So part of the problem in the whole natural history of CSR is the natural history is so good, unless you do a big enough trial, you'll generally show a positive outcome.
So I would like to just state I think I'm stating the very obvious here, that fibrin CSR is just the manifestation of something happening basically. And from that point of view, if you diagnose a CNVM, you no longer really call it a CSR. Then your treatment modality changes to anti-VEGF. And when you don't find a CNVM or a NET by whatever means you have with you, whether it be FA, ICG or octa, if you don't find a NET, then you are really dealing with let's say a fibrin CSR, and therefore lies the confusion of how to manage it with micropulse or PDT or those things. Now, I just want to add a small interesting thing I had with your patient. You found a net, a vascular net, and you had fibrin. Would you do any alternative management to prevent that from fibrosing?
Only?
Would you do something additional to prevent that fibrin from fibrosing?
And that's why I didn't, because I was worried about fibrosis.
Would you add steroids?
Huh?
Would you add steroids? Steroids?
Steroids? No. He was not on steroids.
Would you add steroids?
No. No, I don't have that guts.
The cat among the pigeons. I think
You're being very
No,
naughty.
any of us will do PDT in those cases with fibrin. Anybody has any experience on PDT in fibrin? Yes, you are done. Lot of fibrin. Nothing will happen.
No, it's,
Okay,
it's
then,
obviously a bad
next time probably that would
no,
happen.
it's a bad prognostic sign, but no, absolutely it can respond. I've had patients with massive fibrin, and we've done, of course, we treat all of these patients with low fluence PDT, and yeah, you can have a very dramatic improvement, but yes, you're absolutely correct, as everyone has said, there is a risk of fibrosis whether you do the treatment or not.
Then that may be a better treatment than anti-VEGF, because as he said, there is no VEGF upregulation in CSCR.
So I have a question for the panel.
Let's complete the topic.
Yeah.
Yeah, on this topic only. So sometimes we have this CSR with fibrin with the leakage in the bang in the center of the fibrin. So and the SARF is not resolving and you don't see any net on the opta. So basically you are treating a CSR with the fibrin with the leak in the center. So how do you really treat those patients? Because laser really does not work. It is not possible to, everything reflects back. So a question to the panel.
He's got rounded by saying micropulse.
But how do you
Can
understand?
you speak micropulse anyway?
In the center of the fibrin.
Yeah, it's a painting. We call it as a macular painting. It's a fovea-friendly laser. Okay. Of course, the PDT is the first choice, as Dr. Adnan Tawil said. But if they are not affordable, then the rest we go in for the subthreshold micropulse.
So we can do PDT in the fibrin.
That next question.
Where there is a leak.
So one of the questions is, I don't see a lot of fibrinous CSR in the UK population. And so I don't have a lot of experience, so I was interested to hear Vasu. So we know in the original PDT studies for AMD, in the animal models, if you had anything in front of your RPE, you massively attenuated your ability to treat your RPE. But we know with CSR, you really don't need a lot of energy to get through it. So I'm encouraged that you're getting positive. Do you know if it's written up anywhere, outcomes of PDT on fibrinous CSR? I'm not aware of it. It's probably mixed up in the RCTs.
Mahesh,
No.
would you like to?
This is regarding, in continuation to what Uni was saying about steroids. When I'm going to the literature, there is this expert panel thing in IJO. This is by J. Chablani. One of the experts, Giridhar and others had written that one of the experts has mentioned a role of steroid, like he uses steroids in CSR in certain situations. I was just wondering if anybody else does. So the presence of inflammatory markers like high reflective dots, would you use steroids?
No, but sir, to your question,
I think you are also
part of that.
But nobody bothered to comment about what that that person had mentioned. So
Yeah, because I don't know. We have had patients who had even intravitreal steroids injected, developing CSCR.
you have had or you not?
We had patients, one in Madurai and one we had.
No,
patient.
right now
No,
we know that not all CSR is same. So
No.
it appears as though CSR
No, what
is
I'm saying is, it has not about skin creams or inhalers. We had patients developing CSR following intravitreal injection of dexamethasone. So I would not recommend steroid as an intravitreal steroid as a treatment for fibrin, because at
No, I'm
least
not saying fibrin. In select situations, there is this particular, I don't remember the person's name, that one of the third author experts has mentioned
Yes.
that they would use steroids in select situations.
I would disagree to that.
So, okay, so I think that points out that there's always one more way to look at things. And sometimes they are completely contrarian. Dhananjay, you wanted to add something?
Sir, this PDT is low fluence PDT for fibrin CSR. I do not think that there is any scary situation to go. We have a lot of
I
experience.
agree
on
with
that.
you. I mean, that's not.
Yeah, so I think the discussion has gone rather too far actually, because I think we are putting the cart before the horse. It is the abuse of steroids which causes fibrin in the first place. And we are thinking of treating fibrin with steroids. So that's part one. The second thing is fibrin does not indicate the age of CSCR. I have seen it several cases with acute CSR also. I showed a case of a pregnant woman who had a very short duration. So fibrin doesn't mean chronic CSCR. To confuse it with CNVM is a different ballgame. Whatever you are comparing apples and oranges, because CNVM develops typically very late in the course of a chronic CSCR. Fibrin can happen in acute CSR as well as in subacute or chronic CSCR. So that is not to be confused with CNVM. And I think steroid should never be given.
So the point I was making was that the diagnosis in the presence of a net isn't still fibrin CSR. It's a CNVM net which will probably cause the fibrin. And one of the methods of preventing a SREM, from fibrosing is steroids.
Okay, I think last comment from Mona, and then we.
I think people who've been doing PDT may have seen occasionally a patient who throws up a huge fibrin response and scarring. If you do 20, maybe you'd see it in one. You do focal laser, you see a CNVM occurring earlier. It does happen occasionally, it's happened to me. That means when there is fibrin, there is a possibility that there may be a CNVM underneath. It doesn't have to be there. If it's an acute phase, it may not be there, and very often, Rupak, that kind of patient settles on its own, you may not need to treat. And I can't resist but having a dig at Dhananjay. Just a small enhanced depth imaging will explain why the elderly gentleman, the professionally successful woman, and the housewife can still develop CSR.
Thank you.